At the COMy this year, I'm also joining colleagues who are experts in the field to discuss some current and future implications of MRD in myeloma. And one of the aspects that fascinates me the most, and I think that's most almost immediately usable, is really embracing MRD as post-initial therapy, as the most powerful prognostic factor. And that on itself alone should position us to identify patients up on their response to therapy who are at high risk of relapse and therefore should be candidates for experimental therapeutic approaches. But conversely, patients who have an exquisitely excellent response to the initial therapy and who are then candidate for treatment escalation. And that should really be the step towards ending the one-size-fits-all approach that has really been mainstream in myeloma, where we design trials mostly based on the patient's, based on patients' eligibility for transplant more than anything else. This symposium is also reviewing several ongoing and future trial concepts. For example, the US-based AURIGA study is studying the use of combination of daratumumab and lenalidomide versus lenalidomide alone in patients who are MRD positive after autologous transplant. Also, we reviewed the MIDAS studies currently being run by the IFM, which is a fascinating study that deploys longer and intense induction therapy, and then separate patients with MRD negative, they're candidate for strategy that omits transplant, and patients who are MRD positive for which we're testing whether double transplant is superior to a single transplant, followed by innovative maintenance therapy. And on our own group, we are embracing that notion by launching with the MASTER-2 trial, where patients receive induction therapy with 4 agents, and patients who are MRD negative are randomized to a standard strategy versus strategy that omits transplant. But for patients who are MRD positive, they're randomized between a standard transplant followed by Dara-Rev maintenance strategy versus an innovative strategy with transplant followed by a BCMA T-cell engager, teclistamab plus daratumumab. And regardless of the path, we will cease therapy and monitor MRD on patients with sustained MRD negativity, that's MRD negativity 12 months apart. So I think the future is very bright. There's a long list of trials that will start asking questions in MRD-defined specific patient subsets. And I think that's where the future is headed.